alaikum. I need concentration, please. So the first case is she's currently a 4 years old girl. She presented 18 months ago with abdominal distension and vomiting. There were on abdominal examination palpable masses. So her initial CT scan showed both kidneys are full of solid masses, and especially on the right side. And she was diagnosed with bilateral nephroblastomastosis plus or possible bilateral Wilms tumor. So we got a consultation from the oncology, so we decided to go ahead with chemotherapy according to the COG guidelines. Unfortunately, she received 6 weeks of chemotherapy, but without any noticeable response on her follow-up CT post-chemotherapy. Actually, it might be even got bigger on the right side than the initial CT scan. So we decided to go ahead for exploration, and we did a right radical nephrectomy. We couldn't do a partial nephrectomy on both sides, so we did right radical nephrectomy and left partial nephrectomy. Actually, it was not a partial nephrectomy. We did wedge resection on the one of the tumors on the left side, and the tumors that is near the hilum, which was pointed there in the right, in the left lower slide, it was very close to the renal hilum, and it was very adherent to the renal vein, so we couldn't excise it, and there was a risk of injuring to the renal vein, so we decided just to take the peripheral lower pool tumor as a wedge resection for biopsy. Otherwise, we were afraid that we will end with bilateral nephrectomy and anephric patient. So we did this in June 2016, and the pathology revealed that there is a Wilms tumor with significant treatment effect with perilobar nephrogenic rests. And the left renal biopsy there was on the biopsy that was taken, there was no evidence of Wilms tumor. There was only a fibrosis. So based on the discussion with the pediatric oncology, we decided to give her further courses of chemotherapy. So she received further chemotherapy cycles, around 4 cycles of chemotherapy. And this is the CT around a year ago, like 6 months after our surgery. There is still, I don't have pointer, but you see near the hilum here, still this mass is there. But there was no other masses could be appreciated in the rest of the kidney. So we decided we're not going to touch her, we will follow her and see. So she came back a year later, this is a recent CT, was done in September 2017. Still this mass is there it's actually very clear here. It is non-enhancing mass.
Any discussion about radiotherapy?
No. Because we observed her for 1 year and there was no changes. Actually, the CT report was, when they reported the CT, that they say it is even lower than the previous CT. So our suggestion was to observe her and not to do anything. So I want just to hear your opinion on this.
What was the histopathology?
There was, Wilms tumor on the right side, but fibrosis on the left side, the wedge resection here.
Did you have a grade of the Wilms?
There was around 5%, less than 5% viable tumor on the.
And then you didn't take a piece of the.
Of the no, it was actually it was between the renal hilum, between the renal vein and the renal artery. So it was a difficult dissection, especially after the chemotherapy. It was very adherent on the left side. Yes.
Any plan to, what do you think about biopsy?
Biopsy, CT biopsy, I think it might be very dangerous because it is just at the hilum. So you might just, that's why we did not do.
Yeah, I mean, at this point, you now have a year of information that shows stability. And certainly this could be fibrosis from the chemo. It could have been a nephrogenic rest, although it's an uncommon place for a nephrogenic rest.
Yeah.
Unlike the lower
Yeah,
pole one,
yeah.
which made sense. This is more concerning. Could have been a node or something like that.
No, yeah.
But at this point, as long as you monitor it, I think your challenge will be what happens if it grows. And then what do you do? Going back now is going to be even harder to resect it locally.
Yeah, the other issue is exposing the patient to more CTs. That's also the thing that we don't like to do.
But you could do MRI.
Because on the ultrasound it was not clear, very clear, yeah. So MRI maybe is another option, but
Or the low-dose CTs, and as they become, but I do think, because if this does grow, and I don't think anybody has any good data on natural history of whatever this is, and that's where, you know, a piece of tissue might have been interesting, might not have changed anything to do that. It'll be important to know and probably report what happens, because this is an unusual situation.
actually what also gave me a relaxation that I don't know, but you cannot compare, but like a couple of months back, I had to operate on a similar kid with bilateral huge tumors, and I managed to do bilateral partial on that kid, and when we had the histology, there was no evidence of viable tumors, were all fibrosis. So imagine we could put that patient aniphoric, and at the end it is all fibrosis. That's why I was reluctant to go ahead, do biopsy or something, just observe it.